we heard how to assess and the pathophysiology of pain and the importance of the role of the patient. So now we have Dr. Barry Quinn from Queen's University Belfast in the UK, who will tell us and hopefully will convince you how to implement a holistic pain treatment plan in advanced disease. Barry, the floor is yours.
Okay, thank you, Mohammed, and thank you, Hans, for a lovely talk and a really thoughtful talk. So yes, I'm going to talk about, well, first of all, these are my disclosures. Nothing surprising there, nothing that would get me before the courts. That's good to know. And my objectives is just to talk about the concept of pain, and I'll explain why I think that's important. And then just look at to review our approach to assessing pain, some of the barriers, and then how we might apply a more holistic approach to pain management. And just to warn you, it will be a challenge, what I'm inviting you to do, but you'll see why I think it's important. So it's interesting that, the pain continues to be one of the symptoms most associated with cancer. I think we'd all agree with that, whether it's multiple myeloma or any form of cancer. And it's one of the symptoms that people fear. Now, I was thinking that over 30 years ago, when I started in Ireland in my nursing practice and working in cancer, this was exactly the same. So in over 30 years, this has not changed. So that's a challenge for us. And we still, as Heinz says, there's more to be done. So pain management, despite the fear, remains a challenge. Sometimes it's underreported. It's often misunderstood by the patient and ourselves, and therefore it can be undertreated. Now, I think there are two reasons for that. One is because pain is personal, and I think the other thing is maybe we are not clear about what we mean when we use the word pain. So this is the normal classification of pain. We're all familiar with it, and Heinz mentioned some of this, but nociceptive, neuropathic, duration, acute and chronic, and then the onset, whether it's refractory, intractable, breakthrough, and incident. But that's not enough. It's not enough. And I carried out a piece of research a number of years. It was published in 2020, asking and exploring with people living with advanced disease about their pain and other symptoms. And they talked about this pain, which wasn't always visible to others, including doctors and nurses and indeed their families. And they talked about the suffering that they experienced. They used this word suffering, which doesn't often appear in medical or nursing cardexes, but it was suffering because it was personal to them. And they felt that people didn't always understand what they were going through. And again, Heinz demonstrated that in one of his studies. And ultimately, patients can feel alone and isolated. And I don't think anybody would deny that feeling alone and isolated while living with advanced disease is a component of pain that is not always addressed in the myeloma setting. So this is a piece of work which has been adapted by my colleagues we work together on managing advanced pain, managing pain in the advanced cancer setting, but was worked by Michael Carney, a palliative care physician. So Michael says that, very often it's like an iceberg. This is true of any symptom. But when we meet somebody in pain or with peripheral neuropathy or nausea and vomiting or breathlessness, much of what we see, what we initially assess is this little bit above the water edge in pink. But actually, a lot of the impact of the pain or the symptom actually is more hidden underneath the waterline, the spiritual, the social, the emotional, and physical. And I think we are reasonably good at the physical. I think we do make some attempts at the emotional, but I think we struggle quite a bit when it comes to the social and spiritual elements of pain. Reasons for that: it takes time. It does mean that we have to dig a little deeper, and it takes courage because it will make us as clinicians more uncomfortable. But the reality is fear pain is a big part of the person's story. And as I say, over 30 years, that has not shifted that fear of pain. So these are some of the obstacles. I won't go into them all, but I think still there is a lack of knowledge of what we mean by holistic pain. So if you think about that more hidden spiritual and social component, and I often say, you know, there is no drug in any drug formulary that will touch social or spiritual pain. So maybe we need to think a little bit differently. I think there is a fear to admit pain. Heinz mentioned one is that maybe it's something to do with the relationship between the patient and the doctor. I would also offer another couple of observations. I think for patients to admit that they have pain is to admit that their disease is progressing. To admit their pain is to maybe upset their family. And also there may be a reluctance to admit pain in case there is any change in their curative treatment or any reducing of the dose. I think on the other hand, there is reluctance sometimes from healthcare professionals, doctors and nurses and pharmacists to ask about pain, because the question is, what can I do? What can I do, particularly in these more hidden components of pain that maybe are linked to the suffering that people describe. So really what I'm thinking about and what my colleagues in this expert group have been doing is, you know, is trying to engage with this more holistic approach to pain management. And actually, I suspect if we do, some of that underreporting, some of that undertreatment might be alleviated in some way. So I think the first thing is we all know the principles of assessment, but it's just slightly worded differently. But really it is about paying attention to the person in front of us. And that really means thinking beyond the symptoms. So not just the fact that the tumor or the myeloma is causing pain, but what does that pressure, that pain mean to that individual in front of them? And what is that pain? How is that pain affecting the quality of someone's life? And again, Heinz made reference to that. The next step is creating time and being present. And I warned you that this would be a challenge. I don't think there's any doctor in the world, I don't think there's any nurse in the world who has extra time in a little box or in a little bag somewhere. This is a challenge for all of us. But perhaps it is only by creating time and being truly present that we might be able to address and assess some of these hidden components of pain. Having spent a bit of time really and having the courage to explore pain with people, we, with the patient, can co-create a treatment plan together and then obviously implement a treatment strategy. And that might be pharmacological, but it may be non-pharmacological, and obviously reviewing to see if it is working. But as I say, it is a challenge, and again, I'm sure this is something that might come up in discussion, because I certainly have had it in other pieces of research I've been involved in, is this lack of time. So some of the assessment questions that might come up are obviously well known to you, but we often ask about the character and the site of pain. So for example, where do you feel the pain? We will ask about any associated factors. So how is it affecting your sleep, your life, your social life, your recreational life, but also thinking about pain rarely shows itself in isolation from other symptoms. And equally important is, what are the expectations of the person in front of you? So for example, I think a really good question is, what are you hoping from your pain treatment? For some people, they just say, Barry, take away the pain. I don't care how sleepy I am. I just don't want to have pain. And then other people says, I will cope with an element of pain as long as I can still continue to be a mother and a father to my children, to be a son or a daughter to my parents. So again, the personal choice. I wanted to move, we as a group wanted to move a wee bit forward, further forward, and we've come up with a different description of pain. So you remember at the beginning I said, I'm not quite sure we always understand what we're talking about when we use the word pain. Are we talking about physical pain, or are we including the social, emotional, and spiritual elements? So while nociceptive and neuropathic are very important, absolutely, and will always be important, this is a human approach to pain, which sees pain, whatever it might be, as some form of disturbance or disruption in a key relationship with the person. So for example, we see pain as a disturbance or a disruption in the relationship between the person and their body. So a tumor pressing on a nerve, a tumor affecting an organ, whatever it might be. Social pain is a disturbance or a disruption between that person and their world, what their world is to them, and it might be their family, their work, and their society. Spiritual pain is a disruption or a disturbance in the relationship between the person and what is important to them, their beliefs and values. I was talking to some nurses yesterday, and I was saying, whenever you come close to what is important to someone, you're very close to their spirituality and what's spiritually important, what is important to them. Spirituality and importance very closely linked. And then emotional pain is a disturbance in the relationship between the person, how they feel about themselves, their emotions. So this is just a slightly different approach, complementary approach, I would say, to very often the pain descriptions that we see and have been using for many decades. So one of the things is we have created, this is not an assessment tool. Some people say, Barry, we have so many assessment tools. This is exactly what it says. It's a conversational tool. And what it is it can be used in clinical practice where when the patient is waiting to come and see the doctor or the nurse, they may ask, just circle 3 words that maybe best describe your pain today. Now, what this does, you can see that there are words there like the sharp, annoying. These are common words that we see with physical pain, but also uses words like lost, ignored, frightened. And why this is important, it does a number of things. One, it acknowledges that these elements are really important. 2, it opens the door. It opens the door to the patient, but it also opens the door to the doctor or the nurse. And 3, it gives people permission to talk about these important things. Now, again, it takes courage because very often we are not trained to look at some of these things, but I think it wouldn't take a lot of training to enable us to have these conversations and then, if required, to refer on. So, again, these are just some approaches to reducing pain. I'm not going to go into them, but around physical pain, it's about recognizing. Around social pain, it's around support. Around emotional pain, it's really an invitation for us to come closer and to understand the impact of emotional pain. And really spiritual pain very often is about acknowledgement. Very often I say that when we come to addressing spiritual pain, there is no fix-it answer. Sometimes it's about presence, and it's about acknowledging the beliefs and values and how those beliefs and values might have been disturbed. And then again, thinking about whether the person does want to talk to a member of the pastoral team or counsellor. But in my experience, I would say probably 90% of people living with cancer don't need to see a psychologist. A lot of it, what they need is somebody to listen. And that can be a physician, it can be a nurse, it could be any member of the healthcare team, and indeed maybe a volunteer. Again, I'm not going to go into this because the next speaker will go into this in more detail, but again, it's really helpful for us to think about. But I'm just thinking about all of the systemic treatments we're involved in, which can reduce pain, but also thinking of the pharmacologic supportive treatment and non-pharmacological intervention. And then just to say, I'm going to state the obvious, but every single one of these drugs has their own side effects. So if we're going to consider them, then consider the side effects and how we manage those. Again, this is just complementing those treatments by really engaging with the person to ask them what are their priorities. maybe suggesting physical or complementary support, thinking about the family, because while the patient is worried about the family is worried about the patient. So actually it's looking at the whole family system, maybe, engaging with how people feel about themselves, acknowledging again their values and beliefs, and maybe simply remembering that 90% of what people want when it comes to emotional and social and spiritual pain is somebody to listen and to understand and to move away from that place of isolation. So again, in my study, I think this is lovely, but one of the things I discovered was, what caring meant. And patients in the study, or people living with advanced cancer, did talk about the caring that was shown to them by family members, but also by doctors and nurses and other healthcare professionals. But amidst the uncertainty, and there is a lot of uncertainty living with advanced myeloma, the painful realities that each person had to face, caring was perceived as occurring when three things happened. When another person carried out a simple act of kindness. So this is not, we don't need to go to college to learn this stuff. We know it, we've got it. So one is a simple act of kindness, two is a caring attitude, and three is somebody simply to pay attention to them. So we can do it. So in summary, pain is frequently underreported and undertreated, and I think that will continue until we have the courage to really go below the water edge, and we can help one another with that. We need to continue to engage with the physical component, but also the social, emotional, and spiritual dimensions. Obviously, open, honest, and sensitive communication is essential. People want us to tell the truth sometimes when they're ready. They do not want us to tell lies, but they may not be ready for the whole truth today, but experience teaches us that. That's where our expertise comes in. Again, prevention. So often, as Heinz said, we can predict that people with myeloma are going to have pain, but all elements of pain. And together with the person in need, we can co-create a pain management plan, which is addresses what's important to them and to help them to live with advanced disease. So I think that is me, just up about 15 minutes, and I'm going to hand back to Mohammed. Thank you, Mohammed.
Thank you very much, Barry, again, for a lovely and inspiring talk.